I'm going to take this as a true work in progress because I think that's the best use of these kinds of times. So I'm going to talk about clinical research networks, specifically with PCORnet. And this is one that I was asked to take over with Bill Barnett's departure here back in December. And we haven't given this a lot of press on campus, so I wanted to introduce it here, get some feedback on where we're going, and make sure we can promote this appropriately so we can be seen at the national level with it. So the background for this is that PCORnet was kind of set up as an overall network of networks, and we'll kind of get to that, because they're looking to make the process of doing clinical research cheaper and easier, and to get the correct answers for the people who actually matter. And for people who have done PCORI-based stuff before, this is very much involving the patients in the process of doing the clinical research. So the overall vision was really to get these large-scale clinical research trials going to enhance the quality and efficiency of our care for our patients. The way of doing this, kind of their mission statement for this, is really making sure that the patients were involved in the clinical trial at the large scale level, and not just have this as a one-off from the provider or a sponsoring industry related partner. And so this really came to be an engagement of both people, because this is putting patients as part of the research networks, the clinicians themselves who are the ones that are going to be driving this, and then really getting to the health systems for this, because we want them to be part of the recruitment network. And so the overall structure for the PCORnet was to build an infrastructure, and hence my title for this, if you build it, will they come? Because if you can build a network of networks, can you bring the clinical trials that can support that? And that was really the underlying question for it. And so the underlying use for this was really to come from multiple data sources from multiple centers and try to standardize them into a model that we can utilize consistently across. And so really it's into collaborative based research. I was actually presenting yesterday with Jeremy over with our PEDS ID group, and we really were emphasizing this, that our research has gone from individual siloed researchers who were there to do their R01 and build their career, to partnerships, to now being more of a collaborative network effect for it. And I think that's a positive way of going, and that's what PCORnet is looking to do. So it is truly considered a network of networks, and this is just a cool infographic that they had from their thing, so I had to throw it. But it really comes down to is there are multiple networks that are part of this. And so if you look at these, some of these you may have heard some of the names before. Some of these are led by one of our foremost. So Capricorn is led by Abel Coe, who people may remember from back in the day here. And so we really have this spread out network across the country, and each of these networks has multiple sites within them. So we were not part of the original lead networks for it. We came to be under the Greater Plains Collaborative, and this is where we kind of live as our house. If you look at the centers from these are large medical centers across the Midwest into the South. It's really interesting to kind of see the geography of how this ended up for it. And I'm not sure geography really should play a role when you're doing as digital networks, but it is what it is for it. So IU/Regenstrief became the network site from here as part of the overall network system. So if you look back again, we have the overall PCORnet, with Duke being the one that kind of houses the main center from that goes to these regional networks that then comes down to IU as being part of this. Now, as part of that, any of the researchers in these networks can leverage all of the network, which is the real advantage of being a participating member within this. And so when we looked at this, they were trying to get the number of people that are available for this. And so they do the typical breakdown from this, the male, female, the racial, the age groups for this, and then total pools of patients. And so you're getting over 100 million patients that will fall within the networks of the PCORnet. And so this is with it having an encounter within the last 5 years. So if we look at the US as being 330 million, 350 million, somewhere in there, we're hitting a pretty good slice of America, having at least touched one of the network representing sites. So from the Greater Plains Collaborative for this, we're looking at patient volumes for it. And so one of the things to look at here is not only the total patients, but those that are eligible for clinical trials. So if you look at this, KUMC, so Kansas, has more patients than us available, but they're not available for the trial work for it just because they don't have sufficient data for it. So we have both a good penetration of patients as well as depth enough to be able to participate with different studies. And then from our own GPC, we see some of the penetration based on the markets that are in there. So we get fairly good coverage in the systems that they have. And if you look at the PCORnet in general, again, it gets to the over 100 million patients in the US. So it gets pretty good coverage across the country. Very similar to some of our other kind of collaborative systems. So I2B2, Odyssey, they're based on common data models. And so this is kind of their own common data model reference for it. But it really comes down to is we have to map our own clinical data to a common system so that what we say here, or if we run a query on the data here, it matches directly with somewhere else. And so this is a very helpful one, although it's a royal pain to have to map to multiple different underlying systems for it. So again, here we do I2B2, we have an OMOP underlying. This is the PCORnet model that's underlying from this. So we match our Asian patients from different methods. So the overall methodology for how this goes through is that you have a person who has a question. And so this is the simple research methodology that we all do. And so once the person has a question, there is a coordinating center that has what they call the front door. So you can submit your question through the system. And what they do at the front door level is to break that question down into a query that can be used on our underlying common data model. And so once they have that broken down query, they will send out to interested sites, and you can run that query and provide data samples back for counts. And so the initial investigator can then have one entryway in this to have multiple answers from potentially interested sites. So an example of this is that if a investigator says this, we get sent an email from our Kansas group who hosts the Greater Plains Collaborative. They say, hey, here's a trial that's looking for this. And we say, okay, we have interest in this from our own patient perspective, and we run the query and send it back. So Jack has been doing this within our, I don't even know where Jack is. Is Jack around? Oh, Jack's back here. So Jack's been doing this within our data core group for it. And these are quick turnarounds because we're running on a common data model and the query is often built. There has to be some tweaking because not all our systems are the same for it. But that's kind of where it is. And so you get back to the requester and they can have counts. And based on that, they can select which institutions they would consider having as part of their trial as they write in for grant funding, or if this comes in from industry sponsored for it. And so being quick on the trigger to make sure we're responding and being broad with that allows us to have more participation in the clinical trials. So currently we have 5 studies that we're running through this. Again, these are ones that have come through different mechanisms for it. And the big one I'll highlight here is the Adaptable Trial. So some may have heard of this on campus. So this is a fairly large national trial for it. But this is the kind of where we're participating. If you note here, one of the big questions we've had, and I'll get to this in a couple slides, is making sure we have a local PI available so that we can actually participate in these trials. Because oftentimes you'll want somebody, the boots on the ground in the specialty needed in order to get there. So if you see, I get named as the local PI here since I've taken over in December. The one exception here is Kieran Mather, who's doing the local PI from one of the diabetes studies. So adaptable, so this is to give an example of what can be asked for these kinds of trials. And these are kind of big questions that have large populations, who you need to get large samples in order to make an analysis. So adaptable, this is looking at aspirin and looking at low dose versus high dose. for prevention here. And so, as we know from people who have worked with this, it's very challenging to know for preventive technologies, you have to have such a large population in order to see a preventive over a period of time. And so this is really looking at it, and again, they're looking to get 20,000 patients for that. Hard to do from single or even multi-center trials. So this is a perfect setup for what PCORNet is about, which is to get from the network of networks for recruitment. And so they have their whole mechanism for this. You enroll the patient for it. They have their follow-up. There's a web-based system that they can go through so for their own patient-reported outcomes for it. And then there's a coordinating center that does all this from the PCORNet side and follows up for it. So they have web-based for signing up for this. So it's a very simplified mechanism, very simple from the patient's perspective. They talk about getting what's called a golden ticket, which gets them the opportunity to go sign up for these types of things. And then they can go sign up and they get randomized based on that. I mean, from the timeline perspective, again, this is to kind of outline from a high level of how these are done. So this is over a 4-year period for this. So this would be the perfect R01 type of time frame for it. You can get the recruitment for it. You're not looking to say you have to hire people at every site in order to do this. You don't have to necessarily find local PIs that are expertise. You just have to be able to have somebody that can recruit from this and manage from the national level. And so we've been doing this since 2016. And so we're coming up here just in May, I believe we finished the recruitment. So there's a big push to finish this. This is kind of the list of the participating healthcare centers for this. So if you're looking to say, oh, how many people actually do participate, there's quite a bit. And the nice thing here is that we can get breakdowns of who's recruiting where and how successful they are. So even though you saw us as having a significant number of patients, I want to point out here very specifically that we have not done spectacularly well in being able to recruit patients here. So this is one where we have not made these a focus of how we're pushing these kinds of systems, hence this talk today. And so when I look at these, I want to be up here in the Duke Vanderbilt levels for being able to recruit for these kinds of trials. Because the more you recruit, the more likely you'll have other clinical trials that can come to campus, because people will see you as being a successful way of getting patients through clinical trials. So again, we're not pushing the boundaries here yet from being able to do that. The biggest thing that I wanted to kind of bring up for this are the missed opportunities that we've had on our campus for being able to bring in very significant research for it. And this includes one that's relatively recent here. So I'll point to the bottom one here, which is the Preventable Trial. It's hard to see on the small text here, but this is the one that was right up our alley. So this came in right as I was coming in December that was due for having it. And so they required a local investigator, primary care, geriatrician, who would take on for this. And what the underlying is that they were looking to use statins in older adults to prevent dementia. Now, from a Regenstrief Institute perspective, that sounds like right in our wheelhouse of what our expertise is. This was passed around with our aging research group, and it was determined that it wasn't worth the amount of reimbursement per patient that this would recruit. And so this is one that's in the tens of millions of funded study that's out there with multiple participating members for it. And we are not going to be part of that because we could not find someone who would take this on from the local level for it. And so this is what I want to prevent for our future, because these kinds of trials, they're going to look at it and say, oh, the future trial that I'm doing, Indiana couldn't participate for it. We're not going to even ask. So I want to emphasize that I want to make sure that we are participating in everything that we have the expertise to do, which is honestly almost everything that could come out from a clinical trial. And we have to come up with a mechanism that we can quickly allocate this to people who can be the appropriate PIs for it, as well as to be able to do the recruitment piece of it. For our adaptable trial for this is doing, we do a listing through the data core that will say here are eligible patients that we run quarterly. Is that right, Jack? Quarterly. And then produce this to our recruitment team, who then goes out and recruits the patients. We need to make sure that we're doing great identification of these patients, as well as making sure that we have a good mechanism for pushing through with our own patients for it. So really, I want to kind of get feedback for it. Again, I took over this in December. We're just kind of trying to get our hands around this to make sure of where we have been with this, what we can potentially do for it, and really say how can we promote this on campus as one of the resources. As the Data Corps medical director for this, or for the Research Services medical director, I actually want to take this as really one of my roles to say this is the opportunities. So when we go out talking to the groups about our resources for INPC, IU Health, Eskenazi, this is another one that's out there for our researchers to say, here's an opportunity, use this, and it's an opportunity that we don't want to pass up on it. So with that, I actually want to get feedback. How do we get these to be worthwhile on campus? How do we ensure that we're not missing out on opportunities? And I know we have some big clinical trial folks in here, so I'd look for some feedback on what to do.
Could you flesh out just like in a minute a little bit what's expected of an investigator who signs up? Now, it feels like this is going to fall into two buckets. It's right up our alley, like the one you said at the end, which still it was hard for people in their own to sort of find the bandwidth, whatever that meant. And there's the ones not up our alley. I mean, so nobody content-wise. And of course, you'd like to maximize our ability to recruit for many different types of trials. And so what is asked of the investigator? So like when they say, will you sign up? The question I have is, how much upfront work? Because if you're a site on a big grant, there's a lot of work and hours put in. That's the first question. Yeah. And maybe this is less than that. And second, what kind of resources do they give? They don't want to spend much on the PI. Probably most of it is on the recruitment core. So does the person get a relatively trivial amount of protected time? And then finally, on the publication side, since there's an enormous number of people, can you just flesh that out?
Sure. So part of this is the local site PI. So if you're not the one that is initiating the research, so there's two different ones that I want to push. One is that I want to have our own investigator-initiated push, which is separate than what you're asking. So from the ones that are coming in from outside for this, the example for the Preventable Trial, I believe it was like we give you 5,500 up front, and then it's like 3,000 per patient you recruit for this. And if you put in the time of having a research nurse and everything else in there, it wasn't a lot of time for the PI themselves. And so I push this a little bit to, this is very similar to, like in my GI group, we have people who are trialists. So their job is to sit there, be the clinical expert, and we have research nurses in the clinic that they recruit, and they get paid per patient. If you have those sorts of setups for this, the marginal cost for recruitment becomes very low. And for our trialists, what they do is they bank the money that's coming in for this that can support other research opportunities. So for like this isn't going to give you 5-10% of an FTE for your time. So I would not put this as our hardcore researchers, you know, the people who are writing R01s. These are more of people who are in the field, who want to be part of this. And I want to put that when you participate in this, you're more likely that people will come back and ask you for other things as well. So I do think there's an opportunity to have some sunk cost in participating in these trials. From the publication, I honestly don't have a great answer, but my guess is you would be buried somewhere down in the appendices as a collaborator and not as a thought leader for it. And even from the publication standpoint, I think you'd be hard to justify as an author unless you're part of the initial piece of it. Tom.
Just a couple of things. Some of this is a continuation of Kurt's comment, but first I wanted to ask, you showed that slide where you showed how many patients are eligible and then how many patients are in each system total. How much data is enough to be considered like eligible? Yeah, that slide. Yeah.
Yeah, so hold on. So it really depends on your trial of what you're trying to ask. Okay. So we have one that came through that we're going to participate in, which they want a blood pressure reading like 6 months apart from this. So that's a very easy one, and most people have that data point for it. If you have more complexity for it, but you're asking how much depth for individual patient for it, I don't know offhand.
So is it study dependent? Is that what it is?
So each study, so while they'll quote, the 100 million for this, not 100 million are going to have all the necessary information you need. I mean, we see this with our own clinical data here when we're doing our historical. Remember, this is based on us pushing data from our own data resources here into the map.
But is there some threshold to make that slide? In other words, you made that based on something. What were those criteria that determined how much data were enough for a patient to be considered eligible?
I don't know offhand.
Okay. All right. So then one follow-up question.
Sean may know.
So the PCOR nets have some data quality measures, and so in order to get into the system, which you provide your data, this I believe was based on some pre-baked, agreed upon data quality measures. Do you have the right ratio of diagnoses to procedures, meds per patient? So they did some basic assessments to say your data is wacky and way out of line, so we're not going to use it.
So it would seem to me, at least at first blush and based on Kurt's comments, that it would be better if we initiated some studies within that.
Yes.
Okay,
so
either
I
cohort.
Think this group is an initiator.
Yeah. So it would help to know more about the kinds of questions that are feasible. Like when you showed us that algorithm where it says you give in a question.
Sure.
That's a little scary, because you don't know how people are going to disassemble or change that question. And I worry about the potential for sort of the telephone phenomenon, or I guess in the modern day, the text phenomenon, where the message gets changed. So is there anything more about this system that tells people, enough information to be able to assess whether a study is feasible without actually going through this process of asking a question?
Sure. So from the local standpoint here, being one of the sites, we can actually look at our own data and say, do we have the elements that you need in order to do this style? So the front door when you go through this is a free. So that's not costing you anything. You don't have to have the funding in hand to do that. So you can see, this is kind of your fishing expedition to say who out there has the correct data that I would want to write in. From our local perspective, we actually have our local instance here. So Jack, we can come in from this just from a feasibility saying, what do we have? Do we have what's sufficient for your trial? So are we going to be much more different than what we can do with our own historical clinical data here? No, we will actually be less specific than what we can do with our own data, because you're starting to extrapolate this out into a common data model. So if you can't do it with INPC, IU Health data, the likelihood is you're not going to be able to do it with a wider network because you'll have less specificity for it. If that gets your answer. But I do want to emphasize again, from this group, we're R01 writing kind of people. We want to be the investigators who are writing the first author, writing the grant, not necessarily the collaborating person for it. Dave.
So I have a little bit of experience with this group through the GPC Collaborative. They have a cancer research group. Unfortunately, they meet on Tuesday afternoons when I have clinics, so I'm not often able to join them. But what I've observed from a distance is that some of the successful studies have been using this for patient identification for patient surveys or other patient-centered data collection, not only trials. So I just make that observation. And then the question would be, what is your perception of the potential of this network or success of this network for observational studies?
Sure. So it always depends on the question that's being asked for the success that's going to be there. And I do actually think that the patient-generated outcomes is really what PCORnet is geared towards. I mean, if we look at what PCORI is there for, you want to make sure the patient as part of the intervention. So if you had a large trial, colon cancer would be an example for this. You're looking at, have you been approached by your primary care for this? Did you decline it? What was the reason for declining it? And you could do this of colon cancer outcomes based on some of the patient perspectives of screening. So something like that would be where you could identify patients who were age eligible, who had not undergone screening as part of the network, and then recruit them for reasons why they would not do that. And so that would be my theoretical, how do you do this over a large scale? And so like the Adaptable for this, you have a central web-based system where they can go into and enter their data. And so it doesn't matter if you're recruiting somebody out of Los Angeles, as long as you can have that perspective. And so I actually think that's where the bigger win would be from a collection standpoint. And I actually think if we're writing this from the PCORI side, that would be how I would focus it. I know there's some challenges regarding PCORI, and some of my colleagues can probably speak higher of this, of what's going on for future funding levels. My understanding for the PCORnet is that this is at least 2 more years that it is funded. So we have a little bit here, but I will be fully frank, is that they are trying to have us push our congressmen to make sure that they can push through for PCORI funding going forward. So they've actually approached us to one of our local congressmen. It sits on one of the committees that will push this forward. So I got to deal with I didn't know we had this. We have a political liaison office for IU that sits in DC. If any people have used them before. Sure.
So I noticed on that slide with all the studies we missed, the bottom one, Preventable or whatever it was called. One of the investigators listed is a former biostat faculty member of ours who's now at Wake Forest. So do those analysis data coordinating centers go with the PI, or are they a separate kind of proposal?
It's probably however you write it into yours. So my guess is that whoever is the initiating PI will keep their local biostatisticians from that. Honestly, that's how I would write it, because that's who I would trust that's there. Again, from this group, I want to emphasize, here's an opportunity. I think we should explore this for grant funding as an initiator for it. But we also have to be cognizant that we need to be a good participant as well for other sites that are doing this. And there's a lot of value to have our name at least stamped on there for some of these big outcome trials that are out there.
And that last slide you have, is that the Field of Dreams?
That is, yeah. So if you build it, will they come? I tried to do the metaphor here with the ending. So we need to put some local players on the field, and I was joking with Kirk about this. We were saying that we need to make sure that we have interesting titles, because the presentations themselves aren't as interesting. So, yeah, Sean.
So I've heard some really good comments from this group that seem like they should be escalated up to GPC and PCORnet leadership to say, here's some of the questions that our very talented and thoughtful researchers have. What's the answer? How do we ensure that the friction is as low as possible to move things like this forward in a effective, efficient way?
Yeah, and I think one of the big things here is I think we need to make sure we have 2 groups of people. We need to have the thought leaders who are applying for these types of studies, and then I need to make sure on campus we have the trialists who can quickly run these through. There's a lot of advantage from our clinicians to be participating, because this will hit their research metric for promotion, so that they don't have to be first authors or even author as long as they're doing the clinical trials. So we can hit those metrics as well. Brian.
Yeah, I wanted to know how you're maybe leveraging this to expand the data that's available. So we did a hypertension study last year, and we found that we have blood pressures, but only for IU Health and Eskenazi, right? St. Vincent Community and Franciscan Alliance are missing because we're missing those ambulatory practices in the IMPC. So would this be an opportunity to reach out to trialists that might be at the other hospital systems, or a way to bring those hospital systems data into IMPCR so that we can connect it up and leverage that?
That's a complete different topic that I'm very happy to talk about. Yes, we need to get these other systems into place. Getting that done is a political move. I don't think that IHI is necessarily as interested as we are in certain data measures coming from these other hospitals. So my personal feeling is that we need to get access directly into their systems as opposed to having it come through the IMPC. That's on my own personal. Do I think it will drive for something like this for them to participate more? The answer is no. I don't think it will.